Yeah, recording also started. Sir, can we start now? It is 7:35 already.
Yeah, Dr. Sanjeet, can we start? Dr. Sanjeet?
Yeah, hi. 1 minute. Let me
Hi,
just...
Dr. Sanjeet. Yeah. So I think we are already 6 minutes past 7 o'clock, and we have got 36 delegates already available, and people will keep joining. I think in the interest of time, I think we should start the session. Are you okay?
Yes, absolutely.
Right now?
No problem at all. No problem
Will
at
you
all.
be able to start sharing the screen?
Right now,
Yeah.
yes. Share screen. Can you see my screen?
Yes.
Yes, it's fantastic. Can you come on a slideshow mode?
Is it this? This is a slideshow mode.
Okay, fantastic. So I think we should start, and let me start with the introduction. Dr. Gunadhar, are you there? Okay. I think I would like to start with the introduction. Today we have brainstorming discussion on organ donation management and the maintenance. How do we identify the potential brain dead patients? And we also need to understand the concept of brain death, criteria and maintenance of the organ donor. For this, we have Dr. Sanjeet Sasidharan, who is head of the Department of Critical Care at SL Raheja Hospital. Dr. Sanjeev has a lot of accomplishments to his credit. He is one of the renowned and very dynamic intensivists of the India, and he has been keenly involved in scientific and research paper publication. I think he has more than 100 publications by now, and he is also the president of the Pensa Society, which is accredited a nutrition society, and he will be holding this conference next year. And he is very academically involved, and I think he is also involved in starting the protocols with the collaboration with ZTCC, if I'm not wrong. Today we have an opportunity to hear from him about the brain dead concepts, and the management of brain dead patients. We have the audience, majority of them are DNB students, Dr. Sanjeev, to tell you about the audience, And with this, I would like to, give you the initiative to start the program. It's over to you, Dr. Sanjeev.
So
Without taking much time.
before Dr. Sanjeev start, just a small interruption. So just I'll like to introduce the panelists. And so the today's session, as you know, it is a very special session where actually this is one of the important topics for the exam goers, where where they can be asked a lot of questions regarding the brain death and organ donation. So to make this session more interactive, we have many panelists with us. So Dr. Swapnil is working with us as an associate consultant, and Dr. Subhadeep working as a consultant. So first, I would like to hand over to Swapnil for the just brief introduction of the Apollo Mumbai Critical Care Learning Network platform, and then we'll be starting with the session. Thank you, sir. I'm here.
So basically, we have started this Apollo Critical Care learning network platform with targeting as a all students, even if not even student. It is a great knowledgeable series that everyone may get benefit with the for the clinical orientation and clinical practices. Otherwise, all these topics we have trying to cover all the syllabus and updated new topics in our critical care medicine, ultimately targeting to the everyone who is working in critical care medicine department or any kind of academic program or anything like that. Otherwise, I'm very thankful to our panelist and this Apollo Institute as they have provided us this important platform. That's all. Sir, over to you, sir. Sanjit, sir.
Yeah, 1 second. I am just trying to open up the PowerPoint again. It's just out of for Apollo.
Okay, till that time, one more thing I need to tell to the students. Whatever query you have, please put in the chat box. We will discuss each and every query after this presentation.
All right. So I'm going to share my screen now. Just a minute, okay? Oh, is my screen visible?
Oh, yes.
Yeah. Okay, so thank you, Dr. Akhilesh, Dr. Gunadhar, and Dr. Swapnil. And I'm glad that you've started this initiative, the educational series, which is highly important for students, budding students who are going to be the future of intensive care in the country. And what better than a big network like Apollo to do this? It's phenomenal to be talking to an august audience, especially who are geared up to learn, who are geared up to give exams, and at the same time moderated by quite a few intelligent people in the business, which will definitely be a great task to follow up with a lecture. Well, today, as Dr. Akhilesh and Dr. Gunadhar said, we'd probably be touching upon how to identify a potential brain death patient. That's something that comes before you actually figure out brain death. Then we'll touch a little bit on the concepts of what brain death is all about, and we'll look at maintenance and a few issues here and there. Well, we are improving majorly in critical care. Critical care has been going from places to places. It's been one of the most dynamic fields, and still, in spite of whatever we do in critical care, we have 150,000 patients awaiting renal transplants, around 50,000 await heart transplants, and 100,000 are awaiting liver transplants. Remember, we as intensive care doctors, we are responsible for the functional quality of our recipients. That is the prime thing that we must understand even before we start this topic, that it is us who are responsible for what happens to the recipients of the various organs that they receive. Everything that we do would actually have an implication for the organs that have been retrieved and for the patient that has received that particular organ. So how do we get this right? And I think it's all about timing. I mean, critical care is all about timing. The time that you study, the time that you give your exam, the time that you land up in a particular job, the time that you give the antiplatelet agent, the time that you start the patient on an antibiotic. Everything is about timing. So here again, there is nothing but identifying the particular patient at the right time. So let's look at a case. Okay, let's look at this case. This case is a female that was involved in a road traffic accident followed by a cardiac arrest. She was resuscitated on the spot and was brought to the hospital with an extremely poor GCS. And the sodium was found to be 158. Is this a potential brain death organ donor? That's the first question that we must answer. See, this is a female. This is a patient who underwent a road traffic accident, fairly regular kind of case. There was a cardiac arrest on scene, resuscitated phenomenally, brought to the hospital, poor GCS, sodium was found to be 158. Well, whenever we look at potentiality or whenever we look at anything that is concerned with understanding or sensitivities, or for that matter, positive likelihood ratios, we look at scores, tables, measures, pointers, and classes. This is what we look at. So is there anything that actually tells us about this? So, well, earlier last year, we had a study that came by, and there was a beautiful score that looked at prediction of brain death after out of hospital cardiac arrest, called as a brain death after cardiac arrest score, BDCA score. Now, this score is something that as intensive care doctors, we should know. Now, what is this score? This score is a phenomenal score that gives an area under the curve of 0.82 with the confidence intervals of 0.77 to 0.86, which basically says that this has a great chance or a great potential to indicate that patient who is potentially brain dead. And what did they do? This was basically from two studies. One study that was the erythropoietin after cardiac arrest study, and another study that was cyclosporin after cardiac arrest study. So they looked at all those patients, totally 564 patients, and they looked at the primary cause or the primary association of those patients that were brain dead, and what was the association. Though they found females, non-shockable rhythms, cardiac cause of OHCA, neurological cause of OHCA, natremia at 24 hours, vasoactive drug at admission, and they put them all under point schemes. And they found that brain death occurred in 420.4 and 67.7 patients with a score that was less than 20, 20 to 50, and more than 50 respectively. So here you have a score which actually looks at simple things. They are not great, they are not big laboratory investigations. They are very simple things. Female non-shockable rhythm, cardiac cause of OHCA, that is out of hospital cardiac arrest, neurological cause of OHCA, natremia at 24 hours, and vasoactive drug at admission, and put in a score for them at admission and at 24 hours. Well, look at the three prime things that we look at: non-shockable rhythm, high scores; neurological cause of OHCA, very high scores; and sodiums that are at very high. That's another very high score. So let's look at this. Look at our patient bank. It's a female out of cardiac arrest as a result of asystole, and the sodium was 158. The score is definitely more than 50, and thus this is a prediction of a potential brain death patient. So a score that looks very good, validated very well in a larger cohort of individuals, and probably something that we can apply on bedside to understand whether this should be a potential organ donor. And that's why to be vigilant is very important. Let me give you another case. This is another fairly regular case, a case of a 53-year-old female who was brought to the ER. He had a history of chest pain, arrested just outside the hospital. There was a 35-minute CPR, and immediate CT was done. PAMI was done. ECG changes because it was noticed, and hence a PAMI was done immediately and was shifted to the ICU. Now, what did we see at that time? We found sluggishly reacting pupils and a minimal cough. Well, the initial CT was this. Okay, it's not good, but it's not bad either. It's got nice ventricles. We have some gray white matter differentiation, but the gray white matter differentiation isn't as good as it's supposed to be. Well, what happened the next day? So what happened the next day? 1 second. Okay, so let me just change this. Okay, so what happened next day is that within within few hours, I mean within 36 hours, what we're noticing is a clear-cut change in the gray white matter differentiation, and now it's looking really bad. And at 40 hours, there are no brainstem signs. That means within 40 hours from admission into the ICU, this patient has got no brainstem signs. And if we hadn't done the CT again and again in advance, we probably not picked them up. This patient is one of those patients that would have benefited and helped many patients. Of course, there are a lot of intricacies on PAMIs, a lot of intricacies on the way the patient came in. There would be a lot of there were a lot of implications on the on various organ systems. But however, this is one of those potential brain death organ donors. In India, a large number of lives are lost every year, with over 1 million suffering from serious head injuries. Well, the prevalence of brain death among traumatic brain injury is 10%. That's quite high. Just imagine if there are so many millions of people that are suffering from serious head injuries, and the prevalence of brain death is close to 10% in this particular illness called as traumatic brain injury. Definitely, this is one of those potentials that we can look at. And 3 simple investigations: absent pupillary light reflex anisocoria, or bilateral dilated pupils, and absent motor responses, 3 brainstem signs apart from cisterna ambiens and brain herniation, comes into a score called as a BD, that is brain death neurological score, that is seen very regularly in the Far East. They use it very regularly. And here again, the area under the curve for the score was 0.81, a very good score for prediction of brain death within 3 to 5 days. And this is that particular data that looked at 79 plus 25 patients, less than 7 days and more than 7 days, easily showing that we could probably predict the potential for brain death with the area under the curve of 0.81%, which is 0.81, which is not bad. That we are predicting this 3 to 5 days earlier. Well, we are definitely progressing in this domain. We are progressing quite well, and biomarkers is the way to go in all these things. However, I do feel biomarkers is a relentless pursuit of the biomarker industry to prove us wrong. But this is one place where it will probably help us, I feel, in the future, where combination of 2 biomarkers, GFAP and USHL1, and 3 biomarkers were highly predictive of brain death with AUCs much greater than what we just now discussed, 0.9. So this is going to be the future, and probably we are going to see biomarkers in brain death very soon. This is a study that was done just recently, a month ago, and probably we might see more of this in the near future. Well, let's go back to the concept of death. Now that we know how to look for potential brain death, the concept of death has been something that has been hugely historical. It starts with 1959 from Coma de Passe, and history was created after that till 2010, where American Association of Neurology publishes updated guidelines based on brain death. So it's been a long drawn affair to actually diagnose brain death. Conventionally, what we call usually is circulatory death. All of us around the globe know circulatory death is death, and that is what even the lay public understands. However, how do we relate circulatory death to brain death, or how do we compare them? How do we compare them? That's what is what it is. And what is brain death per se? Well, brain death could be whole brain death, it could be higher brain death, or it could be brain stem death. What we are actually looking at in India and in various other countries is brain stem death. Now let's go to the concept of what these are all about. Whole brain death is basically cessation of the integrative functioning of the organism as a whole, whereas higher brain death is a dissolution of personhood. Simple. This is the simple definition between whole brain and higher brain death. Well, what we are going to look at now is a small part of the brain called as a brain stem death. And henceforth, when we say brain death, we're talking about brain stem death. And that's what we are using as a criteria for brain death. But what is brain stem death? Well, brain stem death is actually a complete loss of the reticular activating system from the brain stem and the autonomic nervous system from the brain stem. Now, what does this do? What does these 2 things do together? They cause problems with respect to the brainstem nuclei, thus impairing the capacity or losing the capacity for consciousness and losing the capacity to breathe. That is what is all about brainstem. And this concept is something that we must understand, that this patient cannot breathe without the ventilator, and this patient cannot be conscious at all. This is what is brainstem death. So what happens over here is, whenever we are coming towards brain death, who is actually responsible for the certification? Who's actually responsible for the certification? Well, as per the Transplantation of Human Organs Act 1994, there are 4 people who is responsible for certification. And one is in charge of the hospital, the registered medical practitioners in charge of the hospital. The second is a specialist, which is nominated from a panel of names approved by the appropriate authority, a neurologist, a neurosurgeon, or a registered medical practitioner treating the person, and the registered medical practitioner treating the person whose brainstem death has occurred. That means these 4 are in charge of actually certifying brain death. However, every hospital will not have a neurologist and neurosurgeon at that particular moment, and hence there is a small criteria to this, that if this neurologist or neurosurgeon isn't there, then you can have any other member from the panel of names that are approved from the appropriate authority. So it could be an intensive care doctor, it could be any other one who's from the panel of names approved by the appropriate authority. So it's not binding that you should have a neurologist or a neurosurgeon, but you should have the registered medical practitioner in charge, the person looking after the patient, and 1 person from the panel, 2 persons from the panel approved by the appropriate authority. So who actually does the testing? Okay, this is certification. Now, who actually does the testing? Well, an independent registered medical practitioner, being a specialist, to be nominated from the panel. These are the ones who's actually doing it, or a neurologist or a neurosurgeon is the one who's going to do the real test. So now, by the end of now, we've actually understood identify the potential for brain death person. We've understood what is brainstem death, and we've understood who does the testing. Let's go ahead now. So it's important that we again and again remember that we need to recycle organs and not just plastic. And let's go to now, how do we get this done and how do we get this right? As I told you, we are responsible for the functional care quality of our recipients, and the next couple of slides will actually determine how our organs go to another patient and how our patient responds. So we have understood what is cerebral death, there's trauma, there's hemorrhage, that per se causes neuronal injury, neuronal swelling, increased intracranial pressure. The ICP is more than the mean arterial pressure, and that is incompatible with life, and that is what brain death is all about. Well, what occurs in brain death? What occurs in brain death is something very interesting. If there is an extreme catecholamine storm, and hemodynamic instability that occurs, which thus relates to renal hypoperfusion. It causes endothelial activation, a huge immunological activation, and an intense release of catecholamines. This occurs, which actually causes a sudden deterioration of the condition of this particular patient at that particular or around that particular moment of brain death. And a prolonged brain death causing this will cause a prolonged brain death causing high rate of tubular necrosis is what it appears. If you look at this is the relationship of heart rate and mean arterial pressure, the relationship of heart rate and mean arterial pressure to brain death. So it's at so what it clearly shows is that there is going to be a severe hypertension and a tachycardia at the phase 1, which is evident at the end of 1 hour of brain death, and at the end of 3 hours there's going to be a sudden drop of the blood pressure, a sudden loss of motor activation, pupils getting fixed and dilated, and everything going for a toss. The mean arterial pressure going down as catecholamine stores are suddenly depleted after it has raised immediately. So there's going to be a swing of blood pressure. This is what I'm trying to say. There's going to be a swing of heart rate. There's going to be a swing and a clear change of the vasomotor stability of these particular patients. So the first thing we see in these patients is a loss of vasomotor tone. Systemic hypotension is as common as 97% of cases when you have patients on going into brain death. So this is something very, very important. Almost you can see 97% of cases having systemic hypotension. So loss of vasomotor tone is the first thing that will occur. The second thing, as we showed, was the extreme inflammatory cascade that occurs with a huge response of TNF alpha, interleukin 1 beta, interleukin 1/6, interferon gamma, and this is going to have an inflammatory cascade which may cause problems with respect to organs. And the third thing that is going to be seen in our patients is electrolyte abnormalities. We clearly know that as the recipient's serum, donor serum sodium increases, the recipient serum creatinine will go higher and higher. This is something that is very, very important, clearly indicating that we are responsible for our patient's future, for our recipient's future, very clearly. So what would be the answer to getting an effective organ to a recipient? It means an effective bedside donor maintenance is probably the prime in the chain of successful organ transplant program. And what does this involve? It's simple. It has to be kept simple. And the most important thing is practice good housekeeping. Use extremely standard approaches to issues. Don't think out of the box. Maintain extracranial organ perfusion. Prevent adverse sequelae of brain death. Correct abnormal physiology if it's necessary to facilitate clinical brainstem death testing. Exclude contraindications to donation, and consult an organ donation agency at any time for advice. This is the sine qua non of, and actually the prime things that you must think when you're actually maintaining. Now let's go to the specifics here. What are the must-dos when you're actually having organ, when you're actually maintaining organ donors? Well, you should have a continuous ECG, you should have a continuous pulse oximetry, an end-tidal carbon dioxide monitoring, and an arterial blood pressure monitoring is essential. We know very certainly that there are going to be huge vasomotor swings, and that's the reason we need end-tidal as well as arterial blood pressure monitoring and central venous pressure monitoring. The early urine output is very, very important. Well, central venous pressure monitoring presently here is not for fluid management. It is basically to see how congested this particular patient is, because this is what surgeons want to look at. Core body temperature monitoring is very essential because there's going to be cross hypothermia. We'll come to that in a short while. And input-output monitoring. Now, how do you remember what to do and what are the numbers? It's very simple. Just remember 100 rule. What is 100? Maintain a systolic blood pressure of 100, maintain a hemoglobin of 10 grams per DL, maintain a PaO2 of 100 and a urine output of 100 ml per hour. It's as simple as that. The 100 rule, a Canadian rule that was instated long ago. This is something that we should probably follow. Very simple to remember for donor maintenance. Well, what happens? There are a few things that happens to our patients. The first thing is the autonomic storm that I mentioned, and that's the reason you don't use long-acting drugs. You don't use long-acting beta blockers like metoprolol and stuff that way. We use short-acting agents to combat autonomic storms. If there are going to be arrhythmias, and that is the reason that we try to avoid drugs like adrenaline and isopranoline, which may induce more amount of arrhythmias per se. They can be cardiac arrest. But if there is a cardiac arrest, it's important to resuscitate them, perform CPR, because a large number of patients, even after a cardiac arrest, can go on to become organ donors. Hypovolemia, yes, the resuscitation has to be done, and the choice would remain as crystalloids and balanced salt solution, and it cannot be colloids, because colloids are known to have a large number of problems with respect to bleeding and clotting issues, as well as grouping and cross matching. Hypotension and low cardiac output, the first pressor of choice would actually remain to be vasopressin and maintain a MAP of more than 70 here. Well, one thing that we see in our patients very, very regularly, commonly, is polyuria. Now, this polyuria could be because of a whole lot of reasons. Osmotic diuresis because of mannitol that is given, diuresis because of furosemide that is given. But the important thing that we have to look at is diabetes insipidus. Diabetes insipidus is something that we have to look out very carefully. When to suspect it? Yes, you can suspect it when you're having a huge volume of urine, 4 ml per kilogram per hour in the last 4 to 6 hours, specific gravity of less than 1.005, your urine osmolarity of less than 200. How do you manage them? Well, we manage them by giving vasopressin, usually given as a IV bolus, 2 to 4 microgram every 2 to 6 hours, or like how we usually give vasopressin at 0.5 to 2 units per hour. Volume replacement is something that we need to do. And how do you remember volume replacement? Rule of thumb is 9 liters are supposed to be given to get down the sodium by 10 milliequivalents generally. The fluids generally can be either through the Ryle's tube or through an IV line, CC for CC with 0.33% normal saline or free water through the Ryle's tube. And all medications usually should be reconstitution in 5% dextrose in order to avoid sodium overload. Well, another very important thing is routine suctioning, positioning, and turning. Very often we forget these simple things: routine suctioning, positioning, and turning, and ventilatory techniques that actually reduce atelectasis, because that's how we will probably prevent hypoxia, which is one of the problems that occurs in these particular patients. And it's important to avoid interstitial fluid overload. Simple things that probably we should be doing. What about hormone replacement? Well, that's been a point of contention, but we do believe that if there is persistent hemodynamic instability with an EF of less than 45%, then it makes sense to actually start thyroid 4 microgram IV and then 3 microgram per hour. And if that's not available, you could probably give oral Eltroxin at 100 microgram to begin with, and a methylprednisolone bolus of 50 milligram per kilogram. Well, this hormone replacement can also probably help to combat the extreme inflammation that occurs. Importantly, it's important to maintain sugars between 120 to 180, and a vasopressin infusion, after all, will also help in the hormonal balance that we probably have. So this is only if there is persistent hemodynamic instability or an EF of less than 45%. Now, another thing that usually occurs to our patients is gross hypothermia. Well, it is easier to prevent than reverse. It is not something that we should treat, we should rather prevent. That is why the insistence is on core body temperature. It's important to monitor the rectal thermometer with a rectal or an esophageal temperature probe or a bladder thermistor, so in order to measure in order to keep a tab on temperature, so that you can prevent hypothermia. Always keep a temperature of 35.5 to 37 degrees. What about anemia and coagulopathy? Well, blood coagulation factors and platelet transfusions may be required to correct severe anemia or coagulopathy, and the procurement should be expedited if there is a worsening of coagulopathy. It's very important to correct the anemia and coagulopathy. So it's what you want to do what you usually do it well. Maintain usual vigilance and attention. Approach the problems extremely systematically. Most problems are amenable to solution. Serious problems are actually uncommon, and advice is always available from me or anyone from the ZTCC all over Mumbai or ZTCC at your cities at any time of the day or night. Now let's go to some non-clinical but certain important stuff that also is connected to brain death. So what is the ZTCC, the NOTO, the ROTO, the SOTO? We heard these names quite often, and let's look at a little bit of MLC and organ donation. Well, the NOTO, ROTO, SOTO, all these are just organizations that are regional or zonal or national that actually helps us when we are stuck in one place. Now let's look at ZTCC alone, because that's what we are looking at. ZTCC is formed as per the state guidelines for the deceased donor transplantations for the city. It's based, it is a coordination, it is something that it is registered under the Charity Commissioner. It is for coordination, it is for organ coordination. It functions, it monitors, it supervises, it creates a transplant registry. It also creates a waiting list for the distribution of organs, and it creates awareness for organ donation. So these are the functions of the ZTCC. And who are the members? Well, every registered transplant hospital, administrative head of each hospital, the representatives from NGOs, the press, the law, the judiciary, and government departments are actually members of the Zonal Transplant Committee over here. Well, that is what is ZTCC. The national, the regional, and state are self-explanatory in this regards. Now, what about MLC and organ donation, and what is medical legal cases, and what is the problem with medical legal case and organ donation? Okay, so let's go to what does the Act actually say. So the Act actually says the medical superintendent will request the police to conduct an inquest. The forensic medicine doctor, in case of medical legal cases, will authorize an organ retrieval. This is what is the THO Act 1994 that it says with respect to medical legal. However, in 2014, it was amended further that the RMO would request, no, it is not the MS anymore. The RMO would request the SHO, SPDIG to conduct the inquest and send a copy to the FMD, that is a forensic medical doctor, who would do the PM. The organ retrieval should not be in any way delayed, and doctors should prepare reports about organ tissues that will be retrieved, and a copy is included in the postmortem report. The forensic medical doctor performing the postmortem has to be present during surgery whenever possible, and prioritize postmortem of these organ donors to ensure that grieving families receive the body at the earliest. Now, these were the rules that were set in 2014 by the TOTA and the THO Act in 1994. However, what you must understand is this act has not been taken completely by many states. So whichever state you're tuning in from, you must understand that the THO is still, 1994 is still followed by Haryana, Bihar, Gujarat, Tamil Nadu, Karnataka, Andhra Pradesh, Telangana, Madhya Pradesh, and the TOTA, that is 2011, is followed by the rest of the states over here. So definitely we are not united when it comes to organ donation is what it appears, and that is the reason that every state has got a unique way of how they do medical legal cases, a unique way. So you should probably know what happens in Delhi if you're working in Delhi. You should know what happens in Maharashtra. In fact, Mumbai and Pune have got two different ways of how medical legal cases are conducted. What happens in Tamil Nadu and what happens in Telangana is also quite different. So let's go to what it actually, the crux points that are there in these cases. Step one is always that the family files an FIR. The family files an FIR saying that this so-and-so person has died, or RTA has had a road traffic accident or something like that. The step two is the inquest. Now, the inquest in Madhya Pradesh, Maharashtra, Telangana, Kerala, Punjab, and Rajasthan, the inquest is conducted by the investigating officer from the local jurisdiction. Now, here is where Tamil Nadu, Delhi, and Maharashtra are much ahead, because this inquest is conducted from the nearest police station. It's not from the local jurisdiction, but from the nearest police station. This actually expedites the organ retrieval program very well. Now, timing of organ retrieval in Madhya Pradesh, Kerala, and Maharashtra, the timing is after organ retrieval. So this kind of expedites it faster. The inquest is done even after the organ retrieval in these states. The third thing is to acquire a NOC, a no objection certificate, from this particular authority. So the investigative officer in states of Madhya Pradesh, Rajasthan, Maharashtra, Punjab, and Delhi is from there that you take the NOC. Whereas in the rest, it's the forensic expert. In Kerala, you don't require it either way. So it looks like Kerala is forward when it comes to organ donation retrieval, and thus they have they are doing quite well in organ donation. The step four is a postmortem. Well, in Telangana, Madhya Pradesh, and Rajasthan, postmortem is performed at the same OT where the organ retrieval is done. So at the end of the day, I think probably we've gone through a lot about how we maintain organs, how we go ahead with respect to maintenance, how do we identify the concepts and the maintenance of organ donor. And I would probably end by saying the only gift is a portion of thyself, a very important statement by Ralph Waldo Emerson. Thank you very much. And Dr. Akhilesh and Dr. Gunadhar and Dr. Swapnil, please, thank you. I thank you very much for having invited me to take this particular talk. I hope I've put my point further.
Yeah, thank you, Dr. Sanjit. I think definitely it is a wonderful talk, and I think it is going to be useful for most of the exam goers, and probably it will impart a knowledge what actually good and what is not good for the cadaver and how to maintain a cadaver. So most of the questions are being asked because nowadays the awareness is the most important thing. So if you can spread the awareness, that is, I think, nothing better than that, because still there is a lot of things which the society and the common people don't know. So just to go ahead with the session, I have just one or two questions to you. Like, for example, in many of the cases where we cannot do a apnea test, so can we just go ahead with the organ donation by the confirmatory test per se? Is it valid in the India?
So yeah, so that's a very, very important question. So that's where the ZTCC comes in place. So as of now, the confirmatory tests are not really being taken. The criteria to actually diagnose brain death all over the country as of now is a clinical brainstem determination criteria. It's purely clinical. However, there are situations where there are bottlenecks where you cannot perform an apnea test. And that is the time that we actually do a confirmatory test, which may include a 4-vessel digital subtraction angiography, and things like a nuclear scan, and of course take the help of the zonal transplant committee. Whenever there is a roadblock, it is important to contact the ZTCC and take the go ahead from those people. That is when we actually go ahead. So don't do it on your own. Don't go ahead and do it on your own. We know that at the moment legally only the brain death criteria is purely clinical, and the confirmatory tests are have to be verified with 2 or 3 people from the ZTCC. So that would be probably the best move in these cases, because the law is gray in this area.
Right. And the second question is regarding the sepsis. So most of the times we encounter a cadaver which is having a bloodstream infections. So what are the scenarios where actually this is not suitable for donation, and what are the cases of sepsis where we can consider, means it is a relative indications for the organ donation?
So, when sepsis causes first of all, what we must understand, when sepsis is there and there is a need for a transplant, it is a severe sepsis or septic shock that actually causes organ damage. In most cases, the damage is temporary and sepsis can be reversible in most cases. However, our role ends by actually doing brain death determination and maintenance of organ donor. And we should leave this call to the transplant physicians, transplant surgeons, as to whether this organ can be taken or not. I don't think we should get into that at any moment, because we've got patients who probably are waiting and would be still wanting that particular organ. So that particular call has got separate committees. There are got committees that are there in the same organization of organ transplants, ZTCC, which have got a lung committee, a heart committee, a GI committee, which actually will take that call. So I don't think we as intensive care doctors should take that call to understand whether this patient can be transplanted or not. Our role ends once we have determined brain death and we have maintained the organ donor and we inform the ZTCC. That is where we end. Whether that can be taken is completely by a different organization, and we should not get into that.
Yeah, thanks.
Dr. Sanjit, yeah, you have given good insight about the organ donation. So, I mean, still in India, we have a lot of issues, like not all centers are capable enough to perform organ maintenance and identify suitable brain dead donors. How do we help such small hospitals or the nursing homes where the patient is we consider the non-retrievable centers? So how do we take care of such patients, and how do we execute organ donation from such centers?
So this was something that came up 5 or 6 years ago, and we've kind of enrolled any hospital, any nursing home as a non-transplant organ retrieval center. So what happens over there is there are two possibilities. One, that you have an excellent OT, and second is that you are close to a hospital that has got an excellent OT. Okay, so here what happens is, if by any chance there is a small nursing home, for example, that has got a brain death organ donor, then the important thing is for them to coordinate is to actually figure out whether they are in the NTORC That is a simple thing to do. Just write an email and you can become a part of the NTORC if you have an operation theater. Otherwise, you contact the ZTCC and a person would probably come in over there and help to shift or maintain this patient till it is transferred to an organ retrieval center. So this is something that is something very exciting, because we are wanting more and more hospitals to become NTORCs, or called as non-transplant organ retrieval centers, where organ retrieval can be done and then transferred from here to another place. Or if it's a much smaller center, at least we can provide the logistics and the advice to maintain that particular organ and then move them to a NTORC or a transplant center.
Yeah, so I think
Dr. Sujit, I have one more question. Dr. Gunadhar, if I can take.
yeah, sure.
So basically, at the moment, we are very much dependent on brain death patients, like brain stem death clarification, and we have to do apnea test. But there are situations where we see that patient has circulatory arrest or probably cardiac arrest. They are not dying because of the brain death situation, but they are dying because of the cardiac arrest or circulatory arrest. Can we explore the possibilities of organ donor? What are the challenges at the moment? I know in India it's not still very popular and not very well practiced, I guess. But the overseas, if you see, there are a lot of centers where donors are identified from the circulatory arrest kind of situations also. So what are the difficulties we have? What is the way forward, and what is the current situation in India? Are we really thinking about that? Because I was also part of this, and we had a session related donors and all. What is the situation? What is the way forward?
Fantastic question. I mean, this is a very, very important question, and at the moment, the norm in the country and in many other countries is actually brain death, and not really donation after circulatory death. Now, what is donation after circulatory death? It means that organ donation happens after the heart stops beating, in contrast to donation after brain death, where the heart is still beating. This is also referred to as donation after cardiac death, or DCD. Now, brain dead donors have lost all brain function, but the heart is still beating and blood is still circulating to the other organs, providing sufficient time to organize organ donation. However, brain dead donations are the norm in India and most of the other countries. Now, when you look at brain donation after cardiac death, there are actually two types. One is called as uncontrolled. What you mentioned was uncontrolled, where cardiac arrest occurs suddenly and it is unexpected, and the time to take retrieve organs and put them into the ice is much, much longer. And this time taken is called as warm ischemia. We all know it has to be less than 60 minutes. So that is a problematic condition. When you say uncontrolled cardiac arrest for DCD, it is exciting, but it is problematic because we probably may not reach in within 60 minutes to do all these things. But what we may probably do in the near future is controlled cardiac death. Now, where elective withdrawal of ventilation in an end-of-life situation leads to a cardiac arrest. Now, this is something that probably may be the norm in the future, and we might probably get more organs, because warm ischemia time in them is controllable. It can easily be controlled, and therefore they are much, much suited for organ donation. Well, there are few countries that are doing this, like Spain, like France, like Netherlands. I think we require organs, and probably the future is going to be organ donation after circulatory death. If brain death determination is not, if brain death criteria or brain death is not picking up, this is probably the way it's going to go. And there are even machines that actually maintain patients. It's a quick ECMO getting in, isn't it? Something like that, and that will probably keep these organs alive. Nowadays, you don't need to have to put ECMOs. There are heart that can be actually salvaged and kept outside in DCDs. So this is something that is the future, I think. And very few DCDs have occurred. It is not as of now legalized and not the norm in India per se.
Right. The team's preparation is very much important here. The team has to be ready, a dedicated team, which is going to attain such scenarios immediately and carry out organ donation in such situations. So for that, we really need to reinforce our existing services. And as you rightly said initially, like we are already having a huge waiting list pertaining to the organs like liver, lung, and heart, and all that. So with the addition of getting organs from cardiac arrest will also definitely help us to reduce the long waiting list. And I think we should seriously think about this.
But Dr. Akhilesh, just to interrupt you here, at this moment,
And we
our
were
country,
in a discussion. Yeah, we were in a discussion with Dr. Mathur and all that. We should also try to promote.
At least your voice is not audible. Actually.
Situation. Are we seriously thinking about it? Am I audible now? Am I audible now? Hello? Am I audible?
No, it's breaking.
Hello? Just a moment.
So what is conveyed by
Am I
Dr.
audible?
Sanjit is very, very important. So every organ is precious. Every patient who is a brain dead donor, actually he or she donates or give life to 5 more patients. But if you see in the practical terms, so everybody should be actually aware of how to preserve the organs, how to maintain a cadaver, and what are the actually relative contraindication for donation. So as far as possible, particularly in a young patient, as far as possible, unless until it is a absolute contraindication, I think the main aim is to preserve the cadaver well for the betterment of the donation process. And whenever is in the doubt, I think the ZTCC is the best authority, or the hospital team, or the administration which is in charge. I think they should be always be in the loop. So that is what actually is the job of a best intensivist who is involved in the organ donation process. So with us today, Dr. Subhadeep, he is our consultant. So Dr. Subhadeep, if you are there, if you have any questions to this forum, or any students who want to put any questions from the exam perspective, Dr. Sanjit is here. We can take the questions.
Yeah. So probably I was not audible. Dr. Sanjit, what is the current situation? We were about to set the protocols for. Am I audible? Am I audible now? I'm not audible.
So nothing from the mind side for the timing. So it's a very
No, I think the network is breaking. So one question is from the chat box, Dr. Sanjit, is like in one slide you have shown that there is an increased sodium levels of donor is related to increased creatinine in the recipient. So the student or the delegates want to know, Dr. B.K. Ramya, he wants to know, can you please explain what is the reason behind this?
So what is known is from studies. Now what happens is uncorrected hypernatremia in any organ donor, that has been definitely associated with poor graft or poor graft as well as patient survival in many studies. Now, these are all retrospective analysis that have said that donor hypernatremia resulted in greater incidence of early post-operative graft dysfunction and loss of liver transplants as well as kidney transplants. So this is an association that says if there is going to be high sodium levels, these patients may not these grafts may not survive quite well. This is the issue. It is not that we don't know the reason as to why this occurs, but this is what the entire issue is all about.
Yeah. And the other question
There's
is
a question in the chat box.
Yeah. What bare minimum clinical test we have to perform before calling the neurologist? That is
the neurologist need not be a part of the entire thing. That is first thing you must understand. Neurologists, out of the 4 people, you have one as a registered medical practitioner, the consultant treating, maybe the neurologist, and the 4th among the appropriate authority, one of those people. So if you don't have the neurologist or the neurologist is not going to come in time, you can yourself do the test that is required, which includes test of brainstem and the most important test being the apnea test. So we are normally, when you fill up a form, you have all the brainstem signs and then you have the apnea test. This is the test that you need to do, and you don't need to really call a neurologist unless there is the presence of a neurologist in close proximity. So the apnea test is something that is that we all should know. Pit-pat, the way we should be. How to do the apnea test is something that we all should know.
Yes. This is I think the basic. The intensivist should be the captain of this in this. Where every process is in his hand. Actually, he has the coordinator and he has to coordinate with social worker, the consultant, the neurologist and other team members.
Yeah.
Okay.
Just to interrupt, sir, before I think if all doubts are being solved, I just need to update about one more project we are going to go ahead with. We have arranged one top short course on 21st and 22nd of January of this month, and that will again be is targeted to all kinds of students, including DRNB, MD, IDCCM, CTCCM, and PDCC also. So I'll request all the students to take opportunity of this advantage of this opportunity to go ahead with the exam and kindly go ahead with the feast important point as an important point of view or the practical basis in our critical care.
Yeah, so this course is about mock exams. Okay, so the students can take the opportunity, like DNB critical care students, they can very well avail this opportunity and they can be benefited a lot. So there is a question on the chat box. Philip Karkera has asked, so poor outcome criteria, is there any time period for prognostication in India?
What I'm trying to understand is which of those patients will, I mean, the question is whether so hypernatremia, long period of, longer the period of maintenance of organ donor for more than 72 hours, hypernatremia and sepsis are poor outcome criteria for retrieval in these cases, most and the rest become and still now at this moment we still would think this way, that even then there are potential people who would take up these organs also, because that's the kind of waiting list that is there as of now.
Okay.
So hi, Dr. Sanjeet. So I just have a query from my side. So regarding this organ donation thing, who drives the organ donation criteria in your hospital? Like suppose somebody you found the brain dead in your ICU. So who takes the lead? Like it is intensivist or it is the primary care physician? So who takes the lead over there?
So in our hospital, it is the intensive care doctor. It is left up to the intensive care doctor, and unfortunately there is no formatted team. It is just the intensive care doctor at that particular moment who takes the entire responsibility of maintenance of the organ donor, and then he's flooded with phone calls from all across with various teams calling up and asking him what is to be done. So that is a problem. I do agree to what you're saying, that is a problem, because there's one person looking after the whole thing and left on it cannot. And most importantly, this maintenance should not be done by the junior intensive care doctor. It has to be done by the senior intensive care doctor, because only if it is done well will the organ retrieval be better. This is our overall outcome becomes better.
Yeah.
So no, I'm not talking about the organ maintenance part after declaring the brain dead. I'm talking about regarding the counseling part of a patient who is brain dead, to make them accepted for the organ donation to the family. So who does the counseling part?
That again, there are different guidelines from different states. So what it's always, if you look on a logical and a practical aspect, it is always better that the medical practitioner under whom the patient is admitted is along with you, who has developed a rapport with this patient, to first talk about organ donation in the first place. And if you follow the Mohan Federation guidelines, they basically talk about eye donation along with the transplant coordinator. Understand this, that the transplant coordinator is someone that has been trained for this. So right from the time we are considering, even in the consideration for a potential brain death, up to the time that we are actually counseling our patients, there are three people who are sine qua non for this. One is the transplant coordinator. The second is the intensive care doctor who has been talking to the relatives. And the third thing is the registered medical practitioner under whom this patient has been admitted. Because in our system, largely, this is driven by the physician under whom the patient is admitted. So these three people together as a team will probably be the people who can, because this can be rather nasty. This can be rather nasty. Patients might take it the other way around. Patient might say that you're probably doing organ trade, which is something that is quite nasty and not nice to hear. So that is the reason that it should always be approached by 3 people together.
And suppose you do a first apnea test, and then still the relatives do not accept. So do you know the patient is clinically brain dead and continuing the further treatment is futile? So what is your practice in your institution? Like, do you conduct a second apnea test and stop the ventilator, or you go by the whatever the patient says? We want to continue.
Extremely controversial question. This is what I would put it as, an extremely controversial question. Are you going to be wrong if you were to switch off the ventilator? No, you're not going to be wrong. You're not going to be wrong if you're going to switch off the ventilator, but you're not going to be right either, because if there is a relative in the audience, if the relative in the community who feels that what you're doing is wrong, he can file a case against you, because at this moment, brainstem determination is probably only on the THO Act. That is the problem. But in Kerala, in states like Kerala, where this has gone beyond, there is rules that say that if you have actually determined brain death, you can legally disconnect the ventilator after appropriate authority has been consulted. That is there already come in Kerala, and very soon it will probably come in India too, in various parts of India too, on that aspect. But I can reassure and tell you for certain that they can create a case, but you will not lose the case, because of the fact that brain death is death. That is what we know. So they can create a case because of the fact that legally that has not been pronounced as death in India. As of now, it is circulatory death per se.
Yeah, probably there are a lot of saying it has been passed in the legislations also. Probably it is coming to the legislations also. If it is not probably legally wrong to stop the ventilator, probably.
We don't know, basically. That is the issue. We don't know. The answer is, it is passed in small legislations, but it's like a bill. It's not coming as a bill in the parliament. So unless that is passed, legally passed, or a gazette will not make a difference. It has to be legally passed. So once it's legally passed, then probably we should be. If you ask me, have I done it? I've done it many times. I've done it many times because of the fact that I am in good rapport with my patient. The patient is admitted with us for a while. The patient understands us well. It's all communication. So once you get through that, then there will be no legal hassles. For certain. So 99.9% of the times, it is communication that makes the difference over here. And you can do this per se because you're not doing anything wrong. It is, after all, what you're doing is right. But it is a matter of just legality that comes into place as of now.
Yeah, I also agree with Dr. Sanjit. So I think it's individualized, and but legally, if you say on paper, probably this is still not be means practice. It is a standard practice across all the hospitals, but of course one can take a call.
So so there are many hospitals where they are doing this on a regular basis, and they have not had any problems per se as of now. And I am still yet to. Do you recollect any cases where there has been a problem, or have you heard of something happening? Any other hospital? I just want to know from.
No. Till now, no such. I don't think any such legal issues has come up. But
exactly. So the question comes because it's a wastage of the hospital's resource to continue the support in this kind of scenario. So probably as a doctor, as an intensivist, we should be much proactive to make this bill to pass in the parliament as well, so that the infrastructure load to infrastructure can come down, because there are a lot of times that we continue the futile care to a patient, and on the same day that there's somebody whom we can make a betterment, they don't get a bed in the ICU. So in that scenario, probably it is much more important, and especially when the healthcare cost is so high. Well, it is always that we should try to make a change in the existing system and make it more regular practice to discontinue ventilator when it is purely futile.
Yeah. So I think we are almost going to the end of the talk, and since there are no further questions,
there is one question in the chat box. After second apnea test, how long we can take to retrieve the organs? Sometimes means how much is the that framework we can retrieve organs? Is there any time limit?
So that's a very interesting question. It's a very interesting question. Actually, maximum time after second apnea test required within which organs can be retrieved. It's a very important question, and that's where the clinical skill of the doctor, intensive care doctor, is practically there. So there are episodes where there are certain logistic problems due to which it takes a while. But for certain, we cannot wait. It has to be done in an urgency. But we know of instances where after the second apnea, we waited for more than 48 hours and organ retrieval has been done. And that's where luck plays a very important part. Certain patients will go down very quickly. Certain patients you can maintain. So it all depends on how you have maintained these patients. It actually depends on how you have maintained these patients. And there is no specific time that is required within which an organ can be retrieved. Like if you talk about DCD, it's different. But when you talk about brain death, there is no specific time or a maximum time after a second apnea test. But the later you go, the more difficult it is the organ survival rate comes down. If you look at organ specific guidelines for warm ischemia, it is liver is 30, pancreas is 30, lung is 60, kidney is 120. That is warm ischemia time. So when it comes to DCD, we can talk about that. But when you talk about brain death, there is a blood circulation that is on. So as long as you maintain it quite well, I don't see a reason where there can be a maximum time. But I must reiterate that we cannot just wait for a maximum time. It has to be done in an urgency.
Yeah, so there are incidences where actually even after the second apnea test, the patient has to immediately rush to the theater when he becomes so hypotensive, and then the organ are being retrieved by the emergency transplant team. So it's all the situation depends on how stable and how the logistics challenges are there in that particular hospital.
Because the family also needs to do some ritual activities, and we cannot delay and we cannot play around with the sentiments of the family and the relatives. So if it is done as early as possible after the second apnea test, that will be really great. And can help the family.
Yeah, it becomes quite painful to wait after you have declared the apnea test to be positive for brain death. It becomes quite painful for the family. It's a grieving family and they need the body quickly. So it doesn't make any sense to actually wait. So, but notwithstanding, this is probably something I'd probably look at. What is the maximum time? And we know instances where it has been more than 48 hours because of the logistic problems that have taken place, and we've still managed to retrieve organs, the long-term effects of which we don't know, but organ survival, at least immediate, was okay.
Yeah. So with no more questions left, I think we are going to conclude the session. I really thanks to Dr. Sanjit and for his wonderful lecture, and all the panelists and all the delegates. Almost around 65 students and delegates have attended today's seminar, and hope they have carried out some message, and they at least have carried out some idea to write in the exams. So with this, I just hand over Dr. Swapnil to conclude the session. And we have a very interesting session on the next week on toxicology. So I also request everybody to join 7:30 p.m. Thursday next week. And I will also forward you the link, Dr. Sanjit.
Yeah.
I would like to, like you also.
I'll join.
Yes. Thank you. Thank you. So Swapnil, can you just conclude the session?
Yeah. So definitely, I am very thankful to Sanjit sir, and I am thankful to this Apollo Hospital for providing such a great platform. And all students, I'll again request you to take advantage of this opportunity to go ahead with this learning network. And all these videos will get uploaded on our YouTube channel. Probably we are lagging behind a couple of lectures, but sooner or later you will get a. One more, I will repeat about our top short course. I will again request you all students to take advantage of this opportunity to have this bedside way only, and we will go ahead and we will be glad to welcome you. So once again, very thankful to Sanjit sir and our all panelists, Dr. Gunadhar sir and Dr. Swadip and Dr. Akhilesh sir. Thank you very much. I think we'll wind up over here.
Thank you.
Yeah, thanks.
Sure. Thank you. Thank you very much. Thank you, Dr. Sanjit. Thank you.